So, hello everybody. My name is Rob Wipond. I'm really honored to be here and be able to talk with you today. Thanks so much for inviting me from On Our Own, and thank all of you for being here. And I want to start with that little thing too. Huck said it. I've heard it so often. Like often in these situations, people just want to be heard. Like that can be such an important part of the entire process and can be such a huge contributor to their immediate de-escalation, their long-term healing and recovery. Is just feeling like there's people in their lives who hear them, who don't just automatically dismiss what they're saying because they're quote unquote mentally ill or something like that, but really hear them out and share it. And I hear that when I'm interviewing people. Sometimes people say to me, "You're the first person in all of my 10 years in the mental health system who's actually listened to me." And I'm a journalist, and I'll be like, "Okay, that doesn't sound good." And often they'll tell me maybe there was one social worker, one staff person at a hospital, one person somewhere in their lives who really listened to them, who really cared about them. And that person themselves made a huge difference to their whole experience. So I just want to thank you all for being here today and being willing to listen to all of this. And hopefully you'll take it out into the world. And the next time, you're encountering anyone, whether it be yourself in that situation or someone else, that you take that moment to really listen and hear and touch base and recognize that you're not alone and that people do understand this kind of stuff. So with that as a tee up, I'm going to switch over to my slideshow now. And I do try to not get excited, because there's just so much I want to convey, and there's so many things about this that are important. So you'll hear me battling almost with myself at times, to speeding up and slowing down because I know you can only take so much, but I try to pack a lot into this talk. It represents a lot of research. Okay, so that's just a picture of my book there. If you're looking for references for this talk, they're on my website, robwipond.com. Your consent is not required. So let's just start with a simple thing here. Sometimes people don't know these sorts of things, but so what is civil commitment? It's governed under civil, as in non-criminal mental health laws, and it's aimed at helping people who are generally non-violent, non-criminal, law-abiding people. And common terms that you might hear: involuntary hospitalization, inpatient detention, outpatient court-ordered treatment, sectioning. So these are different terms, or sometimes referring to different types or stages in the process of this sort of term of civil commitment. So again, I just want to emphasize this is quite distinct and separate from forensic psychiatry and criminal law, where the incompetent to stand trial or not guilty by reason of insanity. That is in the criminal area. And everything I'm talking about today is about the civil system. There are increasing overlaps in how people are treated, and that is relevant. But for this talk today, I'm focusing entirely on civil commitment. So what are these involuntary mental health interventions? Often they can involve, and this is really just, Huck covered so much of this, even in his one story, and these are really common. So police apprehension, a locked or semi-locked institution, or it could be forced home visitations if you're on some sort of outpatient commitment. There's security guards, threats. Very common is the pressure to sign in as voluntary. So our statistics on how many people are involuntary at any time, which I'm going to cover in a minute, but they're all skewed because so many people are being pressured and told and baited in different ways to sign in voluntarily. And so that you might be promised, for example, an earlier release. Once we have to commit you officially, well, then you're going to be stuck here for weeks, months, whatever it is in that jurisdiction. And so that's often a threat that's used. But I've seen even worse threats than that. We're going to come after your children if you so much as protest the situation and things like that. So sometimes those threats get very serious. People's belongings are taken. There can be forced stripping, restraints, seclusion, monitoring and surveillance all the time. All of this was described by Huck. Tranquilizing and sedating drugs are the most common drugs used in a forced treatment situation, and these will be injected if refused. You'll be strapped down, stripped. And electroconvulsive shock therapy in many jurisdictions, and most, is still technically able to be given against people's will. How do people feel about all this? Perceived coercion is key to this whole, to understanding what's going on. So if the person feels as if they were coerced, because of course you could technically, in my case, my own father, he went in voluntarily actually at first, and if in that situation you're treated with respect, maybe the doctor says, look, we just really think you are at risk. We're gonna involuntarily keep you here, but hey, let's talk. Let's work things out together. Have you ever tried any medications before? Here, if you have a conversations like that, this does happen at a really good institution or with really good staff people. And in that kind of case, you will hear people say, yeah, I was grateful it happened. I was in a difficult situation. The police were really kind to me. The hospital's nice. I got on a medication. I find it helpful. This does happen. And so I call them kind of nominally involuntary because in a sense, they were treated largely as voluntary patients. But if you start to look at any research we've got or talk to people, as soon as they perceived that instead what was happening is they were being pressured, threatened, coerced, this is more typically what you'll hear. They'll describe it as humiliating, traumatizing, terrifying, brutal, like they were being put in a chemical straitjacket. It was permanently damaging to their lives. They make comparisons to prior physical and sexual assaults. And this, I want to say that prior, as in many people I've talked to who've personally experienced physical or sexual assault in their lives, sometimes even as children, will say their experience in a psychiatric hospital being quote unquote cared for was worse than their experience of this. And I have to say, these people often emphasize it to me. So this is not a trivial feeling at all. People are being brutalized often by this supposed care. Now, you might ask right away, well, what percentages are grateful versus traumatized? And actually, this is rarely studied. But it's obviously dependent, as I said, on institutional practices, right? So, but one US study found that in an outpatient commitment program in North Carolina, they found that 28% of them were grateful, 72% were not. And it's important to emphasize in this case, this was under the auspices of an actual scientific study. Everybody was on their best behavior in terms of the staff and how they were treating people and all of that sort of thing. So even in this case, we have this huge percentage of people who are saying, I didn't find this helpful at all, and moving into things like that they were actually really harmed by the experiences and articulating that in different ways. Now, I want to talk a little bit about the story that's out there before we really get into these statistics and information that I found in my research. So this is the dominant deinstitutionalization story that is out there. Most large state hospitals were closed through the 1950s and onwards. Today, there's been a 96% bed reduction from 330 beds per 100,000 to 11 per 100,000. Funding for community beds didn't follow, so we have a severe shortage of psychiatric beds ever since. There's been tightened rights protecting mental health laws that have made it difficult to commit even the most severely ill. And this has led to mass homelessness and imprisonment. If you haven't heard this story, you're probably not paying much attention to the news media at all, because it's in the news media all the time. It's hard to read a story about mental health issues or about involuntary treatment without hearing this story out there today. And in fact, this is just a brief scan. I found this narrative often with those exact statistics in all of these publications, just as a rudimentary scan, from left to right, everything in the middle, investigative, sensationalist, whoever it is. Now, one thing I want to just mention is every one of them cited the same source. So it was psychiatrist E. Fuller Torrey and or his treatment advocacy center that he founded. So this is important because it's not like all of these organizations out there are doing research on their own and actually coming up with the same number, because then that would be telling. No, what's happening is one organization, and in a lot of cases, one person has completely created this narrative in the public. And now I want to go into this. Every aspect of it is wrong. There isn't a single point here that is not actually wildly off base. And it's really unfortunate that this is not getting more coverage because, as I'm going to show you, some of this research that I'm going to cite goes back years now. So first of all, every study that's looked into the question of deinstitutionalized patients, none of them actually ended up unhoused or in prison, or virtually none. So there were a total of 23 studies and a systematic review across 12 Western nations, including 3 in the United States. They actually tracked the deinstitutionalized patients. So this is the important thing. They actually said, where are those people now? They went out and they found them. And they did this over periods of years. So consistent across all of the studies, less than 2% of deinstitutionalized patients ever became homeless or imprisoned. And there's the particular citation for that if you want to look at it. So you might say, well, what's going on? Well, these commonly cited high rates of mental disorders and homeless and prison populations are actually just what's statistically expected after years of diagnostic inflation. So here's an example. According to the U.S. National Institute of Mental Health today, 50% of American children will have had a clinical mental disorder before age 18. And so that means the lifetime prevalence rate, and various studies are finding this, is that adults will have 1 or more, often 2 or more clinical mental disorders before the age of 45, or certainly throughout the course of their lives. So that number is 70 to 80% of us will technically meet the criteria for a mental disorder. So in that sense, what we see here is actually the typical rates we cite in homeless populations and prison populations are actually lower than the general population in a lot of cases. But I'm not trying to make that argument. I'm just saying you can't really trust what these numbers are in most cases, what they mean, how they're relevant. But if you're wondering, where did we get this idea? Well, people just say something like 50% of prisoners have a mental disorder and we all get shocked. But hey, you know what? 50% of people in America before the age of 18 have met the criteria. So all that's happening is we're actually testing the people in prisons. Now I want to look at the bed numbers. So just so you understand that I'm not just making these stats up, most of these come from an analysis by the U.S. National Association of State Mental Health Program Directors, so the people who actually run mental health program systems across America. And they did a really good study, Trend in Psychiatric Inpatient Capacity, United States and each state. And they did an update recently, so there's a 2017 one and a 2022 one. And then I supplement it. There's the reference for my own report where I look at that one, I draw on the data there, and then I also supplement it looking at some of the community bed numbers. They focused on inpatient capacity. I looked also at other capacity in communities. So what are the real numbers that they found? So first of all, we have to put the 1950s in context. In those days, state hospitals had a wide variety of patients. These weren't all psychiatric patients. They had their long-term care facilities had really not been gotten going yet. So there were lots of seniors just with dementia, people with brain injuries, people with intellectual disabilities, alcohol problems. All sorts of people were inhabiting hospitals, state hospitals at that time. So when we do a study, the actual psychiatric beds were about 190 beds per 100,000 people. So that's our sort of base rate, is how do we compare then today to 190 beds per 100,000 people back then? And important to understand, actually, mental health funding has gone up dramatically since the 1950s. Roughly calculated here, the adjusted for inflation and population growth, mental health funding increased about 30 times over since the 1950s. It's almost a couple $100 billion a year now in America. So this is a tremendous amount of money. Now, inpatient psychiatric beds have increased across the board. So obviously, people today, only something like 1 to 2% of the population ever lands in a state psychiatric hospital. I mean, 1 to 2% of psychiatric patients ever land in a state psychiatric hospital today. People are getting services elsewhere, and that is private and general hospitals, residential treatment centers, nursing homes, Veterans Administration hospitals, and on the list goes. And that adds up to about 124 beds per 100,000 people. Now, it's important to note, this is 10 times the number that Treatment Advocacy Center typically gives out and that most of these news media outlets and legislators cite. Is much higher, and it's only about a 30% reduction from the 1950s. Not insignificant, but not the kind of dramatic, catastrophic drop in inpatient beds that people often characterize it as. Then we have more to add to that. So we have emergency room psychiatric beds, of course, and people say, well, but that's not really a psychiatric bed. But because it's a chaotic environment. It's not a good treatment area. But of course, if we're talking about asylums in the 1950s, the reason we closed those things is because they were chaotic, terrible, harmful environments. So if we want to do a comparison, really we need to kind of include them. And that's 1.7 million people a year, the best data I found for that land in these emergency room beds. There's prison psychiatric units formally, there's foster care facilities, there's the entire troubled teen industry and more. Then we have to add to those the more formal facilities. And it's important to understand that things like assisted living, supportive housing, group homes, these were the facilities we created to actually offset the closure of asylums. This was the driving force of deinstitutionalization. So to talk about it without referencing how many of these kind of beds we have is really nonsense. And they're almost never talked about, even though today, this is where most long-term coercive and non-coercive treatment is actually occurring, is in these kinds of facilities, the supportive housing and group homes and whatnot. So when we don't have really great numbers on all of this, but I found a few states where we did get very good numbers. And in those states, I found that basically they had per capita double or triple the per capita rates of beds from the 1950s. So this is super important. And so in every state in the nation, you should be doing these kinds of analysis to find out how many beds do you actually have and what types are you really missing? Because sometimes you can back up an inpatient facility, but really what the problem is that there isn't like a nice supportive housing place for those people to go to. And so they're being held in an inpatient facility. And people say, oh, we need more inpatient beds. But in fact, what you need is more supportive housing. So in the absence of this kind of analysis, having discussions of how many beds you need or don't need in any community is really quite pointless. And unfortunately, that's what I'd say has been going on. We've been having pointless discussions and meaningless discussions about bed numbers until we get into it. Now, what about commitment criteria? So commitment criteria have actually been expanding dramatically for a long time, for decades, in fact. And this is kind of where we're at today. This is roughly, I'm looking at nationally here, from jurisdiction to jurisdiction, the specifics of these laws vary, but generally emergency evaluations can last for days, sometimes weeks, even over a month in certain states. And that means that in a sense, you really have not even been diagnosed yet, potentially. You may not even be definitely confirmed, quote unquote, to be a danger, but you're under evaluation for that possibility. So it's a very amorphous and general way in which people are detained. And then actual commitment criteria involve risk of danger or harm to self, to others, risk of inability to meet one's own needs. That's the grave disability criteria, it's often called. Or sometimes it's even vaguer and broader now. You might be at risk of mental or physical deterioration, and who or what that doesn't apply to is very unclear. Or a term like persistent or recurring mental disorder, that is, it's believed that you might meet commitment criteria in the future, and so you're committed now. That's not just an Orwellian way of my saying it. That's literally the way some of the laws are written in certain states, in this very Orwellian fashion. If you could be committable in future, that makes you committable now. And in practice, I want to say this quote from Michael Perlin, one of America's preeminent scholars on mental disability law. As he points out, the definition of the word dangerousness itself, we've gone way off the trail from what the Supreme Court said it should be, where it was really true, real, imminent physical danger, tangibly expressed or acted upon in some way. That was how the Supreme Court said civil commitment criteria should be applied. We're way off of that, as you can see in the column here for the criteria. And in actual terms, even when we're using dangerousness, he says it's often vague, amorphous, and inspires in judges and lawyers. And I know it when I see it attitude. And that's exactly what I see. I've seen out there a lot. It's just basically they kind of decide, oh, well, that sounds kind of dangerous to me. Okay, you meet the criteria. And it's very, very unclear what the standard even is anymore. Along with this, one of the most dominant concepts out there that's circulating around, and it's written into some of the laws too, is this idea that people refuse treatment because they're unaware that they're ill, and this seems to then justify any form of intervention. We've essentially characterized a person labeled with a mental disorder as if they're like a person in a coma. It's so fundamentally dehumanizing right off the bat that this notion is extended to that, because this unawareness notion, it's not really explained what that is, but organizations like treatment advocacy centers say astounding things like 50% of people with bipolar disorder have this condition that they supposedly have a lack of awareness. And it's enormously abusive, and it's extremely misleading. So what does it actually mean when you delve into it? Well, first of all, let's clarify for a minute why people actually refuse treatment, because there have been lots of surveys of this. So the most common reasons patients say that they're refusing a treatment are that they find the treatments ineffective and unhelpful. They find the adverse effects are too severe. They don't believe they have a biological brain illness that requires drugs, but instead are suffering from abuse, trauma, poverty, oppression, some sort of spiritual, intellectual difference or breakthrough. They're having some sort of social problems or conflicts, family problems. And so they just don't see it in their own terms as a biological brain illness. They may well understand that they're struggling, that they're suffering. They may even be wanting help. And then the other reason that often comes up is they don't want to be labeled as quote unquote seriously mentally ill. But now you can put that in context to realize why, because the legal consequences of getting that label are huge. They make you subject to mental health law. So you learn that very quickly when you're exposed to this environment. And so you quickly say, no, 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 no. I'm not mentally ill, because if you're not mentally ill, guess what? You're allowed to endanger yourself. You're allowed to do lots of things that a person who's labeled with a mental illness is not allowed to do. And you quickly learn that when you're exposed to this in this environment. So what's actually happening then, and this is what I see, it's in the science, it's in the law and the practice. What's actually happening here is quite simple. There's no sort of fundamental coma-like state that anybody labeled with a mental disorder goes into. Rather, what's happening is simply if you disagree with the diagnosis and you decline the treatment, then that is equated to you have a lack of awareness of the mental illness and your lack of awareness of the need for treatment. And that is literally how it's written into some of the laws, where it's written into laws. And so this is profoundly dehumanizing. It equates declining treatment with lack of insight as this very global concept that is just so abusive. And yeah, so I could go on and on about this. I just think it's one of the most toxic elements of the public dialogue right now about involuntary treatment is to introduce this theme into it. Like, clearly, sure, some people have different beliefs, different attitudes, and you or I may look at that person and go, oh, well, I just really don't believe that such and such is true. So a person may have an incorrect or what we believe to be an inaccurate belief, but that's very different than that's saying they fundamentally lack awareness or an ability to understand whether these treatments are helping them or not, or whether they can speak to other aspects of their situation that they believe might be helpful. So what are the statistics now? What do we know? And I have to emphasize, this is so hard to get these numbers. There's a real problem going on here. I tried enormously as a journalist using freedom of information requests, talked to media liaisons, and had enormous difficulty getting any statistics. Fortunately for me, ahead of my book, a UCLA group, David Cohen and G. Lee, a PhD student working with Professor Cohen, they spent 5 years trying to gather statistics on involuntary civil psychiatric detentions in the United States. And they, like me, found many black holes, but overall increasing dramatically. So, for example, in Florida, they do have good data. They're pretty good data. So doubling over the course of about a decade. Colorado doubling over the course of 5 years. They found overall in 22 states, just over a 4 or 5 year period, per capita detentions increased 3 times faster than population growth. So going up and going up dramatically. And the numbers I found going back to the roughly about the 1990s was the most meaningful numbers I found. And we just saw steady rises since that period, wherever we could get that data. In half the country, that was about 600,000 people. So we're not talking small numbers here, and about 357 detentions per 100,000. And what's important there is when we compare America and Canada, this applies to as well, those two countries to the UK or other Western European countries, it's double, triple, or more their rates. Now, that's a caveat there that they often aren't collecting the data very well either, unfortunately. So maybe we're going to find that they're as bad as the United States. But certainly right now, it looks like the United States is detaining people at extremely high rates relative to other countries. And so I just want to emphasize, this is so important. Like there needs to be some sort of public duty here, do we not think, to monitor this more responsibly and track it? Because this is a huge infringement of civil rights. It's entirely comparable to locking someone in a jail. And imagine if someone said, oh, we have no idea how many people we have in jail. Yeah, what's the big deal with that? Well, this is a really big deal. And it is shocking and appalling to me that governments are doing so little to rectify this problem. And I'd say I have you can have a cynical attitude about what you think the reason for that is. So, and here's the case of Maryland, for example. So in 2021, I requested numbers in Maryland, asking for all emergency holds and longer-term commitments in Maryland. And at the time, very importantly, there were actually public hearings in process in Maryland underway about expanding involuntary treatment. So it's totally in the news media. There are meetings being held, governments leading these hearings. And so I'm asking, well, what are the actual numbers? If you're going to expand it, what are the numbers? So this is the number the state government gave me, and it's important to understand this was CC'd through about 5 different departments. Everybody was involved. They came back with the number 34 people in 2020. So I immediately knew there's no way this is true. And, or, what does it mean? I was asking. And so we had a back and forth, and we eventually clarified together that, okay, the state government really does not hold the data that you are requesting. Once we had clarified, what is a civil psychiatric detention? Where are people being held? They just said, we don't have the data. So, yeah, I just found that really, really sad and really disappointing and ultimately quite shocking. Fortunately, your Office of the Public Defender did have some numbers, and we had some back and forth, and they put the number that year at about 9,000. So that was the real number. But even as they'll talk about, I think, this afternoon, which would be great to get more details on, both of us felt that this was probably not a complete number, that there were still a lot of people who were not being captured in these numbers because of improper processing at the hospitals, improper recording, or just absence of recording and so forth. So we're still not all the way there yet. And this immediately, of course, is a much higher number and makes Maryland comparable to other states in the nation. So who is this happening to? And this is important as well, because there's a sort of story out there that this is only happening to the most severely mentally ill, and they're usually homeless and they're psychotic. And that certainly is one of the groups that is targeted by this. But what I found in my research was a much, much wider spectrum of people are being detained. And what are the ways that they are typically detained? So for example, 911 is the most common way. And here's some statistics. Out of 170,000 police wellness check calls in New York, about 86% of those resulted in psychiatric hospitalizations. And even when there were specially trained mental health crisis teams doing it, they were still hospitalizing at a nearly 50% rate. So this is people calling just annoyed by people in the street, and in one way or another, or trying to help. So whatever their intentions are, just people contacting 911. Another big one is 988. And I actually think that whenever we talk about these crisis lines, we should be clarifying, does that crisis line trace calls against people's will and get them locked up in psychiatric hospitals against their will? Because 988 does it, and does it at an astounding rate. So they give a number of 2%. Well, that's huge. That's 1 in 50 calls where people are being subjected to a police intervention. And that's separate from mobile mental health crisis team interventions. And that the numbers show that that's about actually 10% of people calling with suicidal feelings. So they're simply calling to talk about their feelings, and they're ultimately getting detained in a psychiatric hospital, or at least they're getting a police intervention. We don't really know very well what happens to them after the police intervention. Unfortunately, there's no formal follow-up. But this was about 98,000 people in the first year of 988. So extremely important. And I think people should be very clearly warned that this can happen when they call 988. So a part of this is there's definitely aggressive policing of unhoused people. It's called complaint-oriented policing by a researcher out of UCLA, where he looked at a study, for example, at 90% of police home interactions were initiated by these 911 or 311 calls, people complaining about homeless people sitting or lying on sidewalks, camping, trespassing, panhandling, stuff like that. And so police would either take them to jail, or sometimes it was easier for them, even in the absence of any kind of symptomology, to take them to a psychiatric hospital. And this is being done at a mass systemic level. So in 5-year period, the Department of Justice Civil Rights Division settled lawsuits with multiple states for quote unquote unnecessary institutionalization of tens of thousands of people. So they should be in the least restrictive environment, but they're not. And the primary rationale in most of these cases was that there was no other safe place for these people. So usually they were poor, they lacked appropriate housing in some way. And so the institution would say, well, we'll keep them here because they're safer here. But they didn't anymore meet the criteria for ongoing detention of that kind. So this is a massive and systemic problem, and it's backing up inpatient beds across the country. And now here, I'm just going to run through some of the predominant other ways that I saw mental health laws being used, because I said that was really only one portion, and we don't really even know if it's the biggest portion. It's a big portion in major urban centers, but across the country, I found mental health laws being used for a much wider spectrum of reasons. So most often, family and domestic conflicts, disputes, child protection agencies use these laws. They may decide one person's having a problem and the other isn't, so they'll divert where the children are staying, or they'll take the children away altogether because somebody's being labeled with these mental disorder and somehow meeting commitment criteria, or the person gets committed and they intervene in some way. Families use them against each other in different ways. Spouses use them against each other. Schools, so that we have skyrocketing numbers wherever we have numbers. So Florida, there's British Columbia and Canada have tracked these numbers more closely. And so there's high rates of institutionalization of children going on directly out of schools. So when they're dealing with disruptive or distressed children, school administrators or teachers will contact 911 and get these kids locked up in psychiatric hospitals for a few days, sometimes even longer. It swings out of their control and out of the parents' control. In long-term care and nursing home, antipsychotics are being used for behavior control. So we see mental health laws applied there whenever a family or the person themselves is resistant to these drugs. Streets and shelters, that we said, it's often distressed or disruptive people. Workplaces, I was astounded to see how common this is becoming, particularly in sort of your employee health programs. So and in conflict resolution processes where one side of a dispute might be pressured or forced into some kind of conflict resolution process that involves them actually being compelled into a treatment program of some kind. I found banks, airports, tax authorities, government agencies using mental health laws against complainers and protesters. It's an amazingly easy way to get rid of someone who you feel is harassing you repeatedly or something like that, because they may not be breaking a law, but you can easily get a police intervention if you say that you characterize them as in some way, a danger, mentally ill. Guardianships, this is an exploding area. Mental health reasons are now becoming one of the predominant ways that people are being funneled into guardianships. It used to be dementia being the predominant one, more increasing severe dementia, Alzheimer's. Now mental health in many states where we have numbers, though it's very hard again to get numbers. We're seeing that a diagnosis of mental health, particularly for children who are graduating out of the foster care system, are being funneled into guardianships as soon as they turn 18 or 19. And then there's also clearly politicized uses of it, even though in some ways all of these are political. So I saw mental health laws being used to discredit whistleblowers. In many states where they have heightened concerns around recreational drug use in pregnant people, or they're trying to prevent a possible abortion activity, they may incarcerate women under mental health laws. And some states have actually created their own whole new laws to control pregnant people. And then underlying this, or through all this, or overarching all this, we have these sort of major cultural drivers and prejudices. So economic classism, racism, prejudices about difference or deviance, sexism, misogyny, homophobia. We see all of this, and wherever we can get good numbers, usually they're done at a local or county level, a study will occur, and we'll see very clearly that these things seem to be influencing all of this. Now, one thing I want to highlight here is there's a lot of money to be made. So even poor people, even if you don't have insurance or really any insurance, Medicare and Medicaid come into the picture in a way. So it's typically up to $1,000 or $1,500, $2,000. It's going up all the time. So how much is paid for a patient day? And that's voluntary or involuntary by insurers, one either public or private. And that's much higher than typical prison inmate rates. And so we look at the numbers here. This is from the American Hospital Association data. This is not involuntary, but their total psychiatric inpatient days for 1 year in the millions. And then, so if we just sort of rough in these numbers, we know that somewhere around 50% are formally involuntary in most inpatient institutions overall. And so this is like a $20 billion a year program all of a sudden. So involuntary inpatient treatment is a massive, massive industry. And you would say, well, Rob, if everything you're saying up till now is true, wouldn't this be a really ripe situation for corporations to step in and go, wow, it's so easy to diagnose anybody with a mental disorder and lock them up with these broad criteria and bilk their insurance plan? Gee, we should be doing that for money. You know, if all you're saying is true, Rob, that would be happening. And well, indeed, it is happening, and it's happening a lot. And in fact, the Department of Justice Healthcare Fraud Division told me that mental health care fraud is one of their top priorities, and it has to do with the use of involuntary mental health laws. So here's an example. Universal Health Services settled for $117 million. So this is the biggest healthcare psychiatric hospital chain in America. They have about 200 inpatient facilities. And this was just about 4 or 5 states, to my recollection. There are other states that are still being subject to ongoing investigations. And the lawsuit stated that they were hospitalizing people against their will who did not require hospitalization, and that they improperly used physical and chemical restraints and seclusion to keep these people. So basically, they were locking them up and drugging them up so that they were docile, and then just bilking Medicare or Medicaid as long as they could until they were caught and exposed. And in some cases, they actually use these free mental health assessments as bait. So they say, come on in, we're going to give you a free mental health assessment. And then they just promptly find some pretense to lock this person up and start bilking Medicare and Medicaid. So, yeah. The other thing that's going on, and this is sort of the new front of coercive care, is really in communities. So we aren't building institutions fast enough anymore to accommodate this massive increase of detentions and long-term coercion. And this is where most long-term coercion is occurring, is in group homes, assisted living, and so forth, as I said earlier. So here's an interesting study that across 5 US cities, more than 50% of people accessing voluntary outpatient services had experienced threats to remain treatment compliant with their housing, their social security income, or another leverage held over them. So that's huge. And how does this really happen? Well, often it's being done through assertive community treatment teams. And those are supposed to be voluntary in most cases, although they do implement assisted outpatient treatment, which is involuntary sometimes. And what I found in my research, and seems to be consistent, is in most states, there's now this blurry line as to what their role is and how they're going to treat people, where it's both coercive, it can be quite coercive in either environment. So for example, ACT team member surveys themselves found that 71%, they admitted that 71% of the time they firmly directed consumer to take medications, and down to 32%, they involuntarily committed the consumer if the consumer was non-compliant in some way or did something that they thought was disruptive in some way. And so there's all sorts of gray areas here too as to, well, what was happening in that individual situation to precipitate this. But basically what you hear when you talk with people is that they just feel under constant coercion when they're living in these kinds of community-based facilities right now. If they're getting any kind of supports, they're also often under threat of being locked up at any time. And so they feel like they have to be compliant. So is any of this helping, you might ask? Well, the research here is really scant around the world, but here's just a selection of sort of reviews of what we see in the research around the world, some selected quotes from peer-reviewed literature. So the use of seclusion, physical and chemical restraints are very common in psychiatric hospitalization, despite a remarkable lack of evidence to support their use. Locked wards, constant monitoring, emergency meds are not supported by evidence and are difficult to justify. Psychiatric forced medication is a remarkably understudied practice. Like literally, people were surveying across 20-year period, across every nation they could find, and they come up with maybe 9 half-decent sort of studies that at least address the issue, and they couldn't really conclude much of anything from them. That's what we're kind of staring at here. It's stunningly, as one researcher, and this is a very pro-force psychiatrist, I might add, he said involuntary treatment is based on tradition rather than evidence. And there's no evidence for public safety arguments. So there's no reductions in serious violence or suicides as a result of involuntary detention or treatment. At least we have no evidence that they do any of these things that we're supposedly trying to achieve. Now, on the other hand, there's suggestive evidence that forced treatments do harms, right? There's lots of patient testimonials of those harms. There are known adverse physiological impacts of these treatments that are just too extensive to list. Antipsychotics, the most common drugs used in forced treatment, are extraordinarily dangerous drugs. They have this impairing tranquilization effect. They can cause neurological damage and permanent motor dysfunction. They cause akathisia and agitation that for some people can be so bad, it can drive them into feelings of suicidality or rages. And of course, adverse ECT effects can range from transient memory loss to massive permanent amnesia and neurological impairments. And what we see, and we don't really know what this data means per se, you're free to interpret it as you like, but we do know that every study has shown that there are 100-fold or more increases in suicides after psychiatric hospitalization. So does it make sense to be forcibly hospitalizing people who are, and this is, and I want to emphasize, this is also people who were not suicidal to begin with. So anyone, and this is voluntary or involuntary. So we see 100-fold increases in suicides a few months after psychiatric hospitalization. So does this sound like a wise thing to be submitting people to if they're already feeling suicidal? So in summary, here was a great report connected to some people connected to the United Nations. Coercive interventions in mental health care continue to be used extensively, although there's little evidence that confer any clinical benefits, and they're often associated with negative outcomes. And as a result of that, in the wake of the UN Convention on the Rights of Persons with Disabilities, a number of the subcommittees on torture and other aspects of the other committees that were looking into issues around human rights, they concluded that forced psychiatric interventions are arbitrary detention and torture. And as a result of that, the World Health Organization and the United Nations are both moving towards advocating for not only reduction, but ultimate abolition and banning of forced treatment around the world. And the World Health Organization just this month released a guide for states and state governments to look at to remove coercion altogether from mental health laws. And you might then ask, well, what are the alternatives? So, well, we could abolish it and just begin to ask that question. Say, well, okay, if we're going to abolish it, what else can we do? And certainly the World Health Organization has released a whole bunch of guides on things that you can do within the mental health system. And here are some of the other ones that I would highlight, or ones that they also highlighted. So certainly more housing and housing first type approaches, where treatment compliance is not a requirement of the housing. They're consistently proven to be very successful at keeping people housed. Enhancing community mutual aid of many different kinds would clearly help. And I just say, even if we tighten these laws again, as they were supposed to be tightened, do better data gathering and tracking of outcomes so we know what the heck is actually happening to people. Are they getting better or worse? Strengthen oversight and accountability would be crucial. If you read my book, you'll see I've got entire chapters looking at the tremendous lack of accountability going on in almost every state in the nation, as near as I can tell, where these institutions are engaged in really systemic abuses and law breaking and are just not held accountable. More class action lawsuits, these are occurring and they can be effective, but unfortunately over the long term, they don't seem to really have enduring effects. I think there's something crucial. I would say when we talk about this, we should also separate detention from the interventions. So by that, I mean, sometimes we can all understand, okay, that person should be physically stopped from doing something that really does seem to be dangerous in some way. Okay, but that's a very different discussion than this person should be subjected to invasive psychological or psychiatric procedures of some kind. They should be forcibly drugged in a way that we don't do, say, to someone who is committing a criminal offense. So we really should separate out those two pieces to say, when can we maybe, yeah, all agree, or a lot of us can agree, let's do a detention versus let's actually do an invasive psychiatric procedure of some kind. And yeah, let's separate those two out. And I think with that, opening up the dialogue about psychiatric advance directives. They are on the books in many states. They aren't used a lot, where people can say, if I am going into crisis, here's what I find helpful. Here's what I authorize and don't. That way, if someone did have a positive experience with forced treatment of some kind, they can say that then. But the people who didn't can clearly articulate as well and say, here's what I would like to happen. And of course, non-medical therapeutic options are very popular. And so why aren't they available in hospitals? We've even had a lawsuit up in Alaska where they tried to actually force that. They won at the Supreme Court, but over the years, it got whittled down again. And by that, I mean that they won saying that hospitals had to provide some sorts of non-medical therapeutic options, at least, and only if people refused those could they be forcibly medicated. But that law has basically been whittled down again and is not being implemented anywhere that I know of. So why aren't any of these being implemented? And I think the core problem is here that we need to demedicalize the current legislative authority. So certainly, currently, under mental health laws in every state, physicians, psychiatrists have absolute decision-making power and authority. So they trump all other forms of practitioners of every kind and in every situation, ultimately. And so that's what needs to change, because as long as that's on the books, we're not going to get any change here. One of the easiest things to do would say, okay, let's make this an interdisciplinary team. So maybe that team includes peers, it includes social workers, it includes non-medical practitioners of different kinds, and the psychiatrist is one member of the team helping decide what does this person really need and how can we help them. And I'd go even further to say the patient should be an equal participant on those teams. So that's my talk. Thank you very much.